Hey everyone, I'm Judy. I'm the Executive Director of F.E.A.S.T. Thank you so much for joining us. We're going to get started. Sorry that we're about a minute late, a little technical difficulty. So first I'd like to thank Dr. Leslie Williams for being here with us on the topic of addressing medications like Ozempic in the context of eating disorders. I know it's a topic that it affects all of us as parents in one way or another. And I'm really appreciative that Dr. Williams is presenting it for us here at F.E.A.S.T. So I just want to remind everyone you're coming in with your cameras off and with your mic off. And we'd like to request that you please keep yourself muted with cameras off during the entirety of the webinar. If you have questions, you can use the chat box and you can just write in your questions. And at the end of the presentation, there will be time for Q&A. So now I just want to hand it over to Dr. Williams because I know she has a lot of content and not that much time. So thank you again.
Thanks, Judy, so much for that introduction. And I really appreciate the opportunity to come share with all of you today. So, my goal is for us to kind of delve into medications like Ozempic in the context of eating disorders and hopefully get some of your questions answered. And sorry, my slides aren't advancing. There we go. Fantastic. So, as was stated, my name is Dr. Leslie Williams. I am a family medicine physician and eating disorder specialist, currently practicing at the Mayo Clinic in Arizona. In terms of kind of my affinity for this topic, is that as you can imagine, as an eating disorder specialist, and also I do practice weight inclusive care, it was very challenging when these new medications came on the market because everyone was calling the office, asking about them. We were just getting inundated with them. And my first knee jerk reaction was like, I take care of eating disorders. I really don't want to deal with a medication that takes away people's desire to eat. And it just felt like it was a very muddy waters. And so my first inclination was like to avoid it at all costs. But unfortunately, as all of you know, over the past few years, these medications have become very embedded within our culture at large and particularly within the medical community. So instead, I needed to kind of take a deeper dive and figure out what's the best way to navigate dealing with these medications in the context of knowing that I have a lot of patients that also struggle with eating disorders. So, in terms of our learning objectives for today, our goal is to have a basic understanding of how these medications work and a recognition of why they may be challenging in the context of a patient with a current or prior history of disordered eating. So, in terms of lessons learned, we know that these medications, in a lot of ways, have revolutionized medical practice. As we'll get into later on in the talk, there's more and more indications for use. So, the take home message is that these medications are here to stay. And recognizing that they are going to continue to be part of our landscape, we know that we need to proceed with caution whenever someone has struggled with an eating disorder. And we know from a medical perspective, one of the things that I do is I make sure that I really just provide extensive informed consent for patients prior to initiating this type of medication. And I'll talk a little bit more about what that might look like. So throughout the talk, we'll be using the term GLP-1. Those are glucagon like peptide 1 receptor agonists. That's a mouthful, so I'll usually say just GLPs. And then there's also another class of medications, which is the glucose dependent insulinotropic polypeptides, the GIPs. And we kind of use that term interchangeably, recognizing that some medications have more than one mechanism of action, but in general, kind of in the popular culture, people just refer to them as GLPs. And so I'll be doing that just for simplicity's sake throughout the talk. So this slide is really just to emphasize the different areas, the so many different areas of the body where these glucagon-like peptides and GIPs work. So they have an impact on starting at the brain, appetite suppression, increased energy expenditure. We look to the muscles, they have impact there, to the kidneys, can kind of act like a diuretic, to the liver, can help decrease inflammation, to the fat cells or the adipose tissue, can help increase breakdown, blood vessels, decrease inflammation, pancreas. This is where we'll talk about some of the potential risks because it can impact pancreas injury and cause some issues in terms of pancreas inflammation. Also, the GI tract, diarrhea, nausea, sore throat, and then impact on the heart to help decrease blood pressure, increase heart rate, increase contraction of the heart. So basically, um, the GLP and the GIP work all over our body. And so that's why it's really important when I talk with patients, because a lot of patients request these medications and they're like, oh, I just want to go on this medication for, getting ready for bikini season. I just want to go on the medication for a short period of time. And then I'm going to stop it and be able to, maintain my weight loss. And so that's why I kind of explain to them that there's multiple mechanisms of action for these medications. And it's not just like a lot of the prior medications that we had on the market that work to manage weight strictly from a appetite suppression perspective. So when we talk about the GLP-1s specifically, and we want to talk about their mechanism of action, what they do is they mimic the natural hormone GLP-1, and it helps to regulate blood sugar and appetite. It also impacts the secretion of insulin and glucagon, and it slows gastric emptying. This is an important piece because that's where a lot of that nausea comes from. People who already struggled with how quickly things move through the GI tract, it's going to make that even slower. And so, what I've cautioned, if patients have a history already of like severe constipation or troubles with how things move through the gut, these medications we might want to proceed with caution. And then the appetite suppression piece, which we already touched on. So, overall, they basically boost insulin, suppress glucagon, and promote fullness. And so, as you can imagine, in the context of someone who struggled with an eating disorder, just an eating disorder in and of itself can kind of disrupt those hunger and fullness cues. And then if you layer on a medication that's also suppressing it, it can be really challenging to figure out like what your body needs and when it needs it. And if we look at the GIP medications, their mechanism of action is that they also help regulate blood sugars through insulin secretion. They modulate glucagon and they have a role in fat metabolism. And it helps to kind of improve the insulin sensitivity of the body. So if you think about patients that maybe struggle with certain conditions like polycystic ovarian syndrome or other things that impact the body's ability to really react to insulin, these medications can be potentially helpful in that case. And so we also know that some of the medications have dual action. So they work through both mechanisms, through the one we just went through in terms of a GLP-1 and also the GIP. So you may have heard in the popular culture about tirzepatide or Zepbound. That medication is slightly more effective in terms of weight decrease because it works through multiple mechanisms. So it's going to use both of those pathways, and often patients have a greater impact on their weight loss. So if we want to compare the different medications, this just kind of shows a GLP-1 versus a GIP versus dual therapy. And this just illustrates the fact that if you have dual mechanisms, it's going to be more effective with blood sugar management, weight loss, potentially greater cardiovascular benefit, less issues in terms of having low blood sugars, and a little bit less of the GI side effects that are more common with the GLP-1 medication, as I mentioned, because of that slowing down of how things move through the GI system. So, in summary, we know that they mimic the gut natural hormones, they do all of these different mechanisms. And so, as I mentioned, the idea of being on the medication for a short period of time and then discontinuing will show a little bit later that the data seems to indicate that that would then result in rebound weight gain because of all these ways that it's working on kind of like a hormone level to help modulate not only like how hungry we are, but how our body kind of processes the food. So, when I think about prescribing, especially in the context of eating disorders, we have to take into account the medical, ethical, and logistical aspects of that. And so, I'm going to review each of these and how I kind of approach them. So, in terms of from a medical perspective, right now, these medications are everywhere on the TV, in the news. In the magazines. And so, as a physician, I really try to maintain adherence to the FDA guidelines. So, what situations were the medications approved from an FDA perspective? And I try to stick to that. And what can get kind of challenging for people is that they just see it in the news like, hey, if you don't like your weight, go on one of these medications. And so they don't really seem to understand that the medications have certain FDA approvals, and not everyone in the community is sticking to sticking to those FDA guidelines. I also have to determine medical necessity, review with patients the instances with which they would be excluded from being on the medication, and really discuss treatment goals. Because again, the medications were really meant for patients that have some of these metabolic issues that lead to like downstream medical complications. It was not necessarily, and it was really initially developed for diabetes treatment. And it was just found that, weight loss was one of the side effects. And then they tend to look into other ways that they could utilize the medication because of all of those metabolic impacts that we talked about. But sometimes patients come in and they're like, hey, I have no medical problems whatsoever, but I would like to weigh what I weighed when I was in high school. And so having to have those conversations about treatment goals and what's appropriate from a medical perspective and what might be influenced by their own kind of internalized like weight stigma issues, and then providing informed consent, which we'll talk about. So, in terms of the FDA guidelines, currently the medications are indicated for those who have type 2 diabetes, who have a BMI of 30 or above, who have a BMI of 27 and above, plus some kind of weight related health condition. It's currently indicated for metabolic dysfunction associated steatohepatitis, which is a long name. We call it MASH for short, but those that historically were in what was described as the fatty liver disease category. And then there is a current indication for obstructive sleep apnea, and that is defined. Back to the MASH. That has to be via biopsy confirmed with moderate to advanced fibrosis or a failure or intolerance of lifestyle modifications. And then for the obstructive sleep apnea, the indications are an apnea, hypopnea. So it's like a measurement that they do when you're sleeping overnight of more than 15 events per hour, plus a BMI of 30 or above, and an intolerance to CPAP or some of the other interventions for sleep apnea. An exclusion criteria for the medication use would be a history of pancreatitis, because, as we mentioned, it does have a negative impact on the pancreas. And honestly, the majority of my patients that have been hospitalized after initiation of the medication have been due to pancreatitis. And I think most of them had a remote history of pancreatitis in the past. Medullary thyroid carcinoma, or MEN syndrome, or excuse me, either one of those is a contraindication. Any severe GI issues, like I mentioned, because this also contributes to slowing down. So if people have already had a significant problem, we would want to maybe exclude them if they've had severe GI issues, or at least proceed with caution. Pregnancy or breastfeeding is a contraindication. Recent history of major surgery or upcoming surgery, uncontrolled hypertension, active suicidal ideation. And I put a star there because there have been some studies to show that there may be some association, not that the medications cause suicidal ideation, but there may be some association. So we want to make sure that patients are kind of stable from a psychiatric perspective and a history of severe or allergic reaction to the medication class. So those would all be reasons why not to start medication. And access or insurance coverage is a real issue. So back to looking at it from like that medical, legal, ethical perspective, there's a lot of people that the medications are just cost prohibitive. A retail price, if you just pay for it at the pharmacy, it can be somewhere around $1,200 in the US. If you get it from a compounded pharmacy, which we'll talk about in a few minutes, the price is a little bit lower. And if you get it directly from the pharmacy, so I know Eli Lilly specifically, you can get the medication directly from the pharmaceutical company, and that's maybe about $350 per month. There are some insurances that just exclude this class of medications altogether. I oftentimes have patients come in and they're like, my pharmacy says it's not covered, and they just have elected to exclude the medication. And then there are some insurances that currently have imposed things like a lifetime max. So for instance, my own employer's insurance, we have a lifetime max if you were to take one of these medications for weight management purposes of $20,000. So at around $1,200 per month, that gets people around 20 months of treatment. And so I make sure I have those conversations at the onset because, as I mentioned earlier, we know that when the medication is discontinued, there's the potential for rebound weight gain. And so we want to kind of be thinking about what that trajectory would look like in terms of their ability to stay on the medication, because it might just be an issue in terms of it's cost prohibitive for them. And I think about, especially with kids, if I have a kid that's coming in and maybe they're not highly motivated to be on the medicine, the patient or the parents are really pushing it or something like that. We don't want to start them on a medication, which when we haven't done all of the foundational like lifestyle work and all of that stuff, because again, there's a potential to have a lifetime max of when they're on that medicine. And, that would not be ideal to start anyone on the medication if they haven't kind of, done some other work. So compounding, I'm just going to touch base on this briefly because it comes up quite a bit. But you see all kinds of things on the news about different places that you can get the medications outside of your traditional pharmacy. And so when the medications first came on the market, there was a shortage of supply. And so the FDA allowed for compounding pharmacies to make a version of the medication to kind of help kind of overcome that supply chain issue. And so there were a lot of compounding pharmacies which made a medication that was maybe very, very similar, but they might have added like B12 or something to it to make it slightly different so that it wasn't exactly the same, so that they could fill the need of the shortage, but then also get the medication to patients at a lower cost. But now, as the pharmaceutical companies have been able to currently keep up with the demand, the FDA has kind of rolled back some of those recommendations or those allowances for compounding pharmacies. So that will continue to evolve. So we know that compounding drugs are not FDA approved, and a lot of compounding pharmacies, at least in the US, there is not like a formal, rigorous oversight. And so those are some, concerns. And personally, I don't prescribe to the compounding pharmacies, but I know that a number of patients get them directly from there. And there are other providers who do. So again, cost would be a reason. And if, for instance, they have an insurance that is excluding the medication altogether, and it makes it cost prohibitive for them to get it in another format. In terms of dosing concerns, some of the compounding pharmacies provide the medications in a multi-dose vial. So instead of it being in a one-dose pen, because these medications do require a subcutaneous injection, that a lot of the issues that we've seen around the medication have been dosing errors, especially if it's given in a format where patients have to like draw up the dose themselves and administer it in a separate syringe. So that has been an issue, and it has led to at least the majority of kind of like the adverse drug issues that have been seen with the medication are mainly from compounding pharmacies, are mainly due to dosing error issues. So if we talk about overall side effects, the most common, as I already mentioned, were nausea, vomiting, and constipation. Again, having to do with the slowing down of the GI system primarily. And so those are some of the symptoms. Sometimes those can be overcome with giving people like an anti-nausea medicine. And with all of these medications, when they're being prescribed, they will start very low on the dose and slowly increase. So, as you can imagine, we think about these common side effects in the context of someone who struggles with an eating disorder. Let's say that maybe you had been in recovery for a long time regarding your bulimia, but then now you started this medication, which is naturally kind of causing some nausea and maybe causing you to vomit. And then that might kind of put you in a situation where you're more vulnerable to like resuming those purging behaviors. Pancreatitis is another common side effect, as we talked about earlier, the impact on the pancreas. And again, most of my patients that have been admitted to the hospital after starting one of these medications, it had to do with that inflammation of the pancreas. And so we definitely want to be cautious with anyone who's had any prior history of pancreas issues. And then is some emerging data to suggest that there's the potential risk of decreased vision, or it's a non-ischemic optic neuritis, like a inflammation of the optic nerve that can cause decreased vision. So I think there'll be more to come on that, but I have had one patient experience that. So, I mentioned at the beginning informed consent, and I feel like that's a really important part of considering, especially if someone has had the history of an eating disorder. And so, this is an example. This is the Medical Students for Size Inclusivity. They came up with a great kind of informed consent. There's a link here, but then these are some of the questions that they ask. But I think even before we get to that, if I have a patient who struggled with an eating disorder in the past, or they're currently endorsing any eating disorder symptoms, I'll usually just do like an eating disorder screener. And if I have any concerns, I think before I even consider starting a medication, I'm going to make sure that they have a therapist involved, a dietitian involved, a psychiatrist if indicated, and just make sure they have all of those people on the team before we even consider this, because we know how vulnerable patients can be to like kind of relapsing in their eating disorder. So I love this informed consent because it asks some questions here. It says, do I have any health conditions that should be addressed more directly? Because again, oftentimes patients come in with kind of this magic bullet approach, like, oh my gosh, I've heard about this medicine and it is just going to solve all my problems. I want to start that right away. And, I think the first person that ever asked me for the medication said, I do not want to change my eating habits. I don't want to exercise. I don't want to do all those things. I just want to start this medicine and have it, reduce my weight and take care of all my problems. And so that would definitely be like a pump the brakes situation. Like we need to talk about what are their health issues, what are their obstacles to doing some of these lifestyle indications, and then determine whether or not this would even be indicated in their case. And then next question is, are there screening or preventative care measures that are being deferred for a trial of weight loss? And what that gets at is that oftentimes, again, back to this kind of magic bullet thinking, people just want to come in and just start this medicine. I don't want to talk about, my cervical cancer screening or my colonoscopy. I just want to take this medicine. And so we want to make sure that their overall health is being addressed and that they're not, again, kind of putting all their eggs in one basket, as is like the term, in terms of just thinking that this one thing is going to solve all of their problems. Do I feel that short-term weight loss is worth the cost and potential side effects? Again, because as we stated, depending on so many different factors, we don't know how long patients will be able to stay on the medications. The current kind of data seems to suggest that for most people to maintain the weight loss, this is going to require like lifetime use. And so we don't have necessarily the data for what this looks like 10 years, 20 years. In the context of diabetes, we do, and the the long-term data is favorable, but we just don't know. And so just making sure we have that conversation. And then what about if it results in weight cycling? So for instance, as I mentioned, patients might have to stop the medication for things that are completely outside of their control. They wanted to stay on it, and then their weight subsequently increases. And then let's say, for instance, I have a patient that has a like an out of pocket max at the beginning of the year. And so she usually, her family is able to reach that within a few months. And then she wants to like do all the things because they've reached their max. But then, a few months down the road, the new year is going to start. And then, things are going to be more cost prohibitive. So just talking through those kind of issues. And one question is, if we were to set weight aside, what would make the biggest difference in my health? And so that's really an important question to ask. I really talk to patients, about goals. Like, what is your goal? What is going to make you feel better in your body? And sometimes we're able to achieve that goal without really overemphasizing weight loss in particular. And then, do I need help caring for my body in the body that I have now? So, like, is it that I know I want to be more active, but I just don't know where to go or how to get there or whatever? So that's what that question gets at. So I like some of these questions because it really causes the patients to be more self-reflective in terms of what are their goals. Am I just coming in to ask for this medicine because I saw it on television, or is there some, goal that I'm trying to reach, and is that, realistic or in the best interest of my overall health? And then logistical challenges, we've kind of already touched on these, but the cost and insurance issue, supply chain. At the onset, there was a lot of issues with obtaining medications from the pharmacies. That has been primarily resolved right now. Frequent stopping and reinitiation for a variety of reasons. So, as I mentioned, patients have to slowly increase up on the dose. So, let's say, for instance, you went on a European vacation and you don't feel like taking the medication with you and you stopped it for a few weeks. When you come back, if you start back at the dose that you were previously at, oftentimes those side effects of like nausea and vomiting, all that will be accelerated because you haven't been on the medicine for a while. And so I really try to caution people about the frequent stopping and reinitiation. We talked about the compounding and then just the issues in terms of access for the medication, because we know that a lot of marginalized groups, be it financially or otherwise, may not have access. And regardless of whether a patient starts the medication and for what reason, I can't overemphasize the need for ongoing surveillance. One of my concerns about a lot of these, like, kind of telehealth places where people can get the medications, is that they'll just write a prescription, sometimes never even seeing the person. Face to face. And back to our concern about eating disorders, I have a lot of patients with eating disorders. That's how they're getting the medication, because they don't want to be weighed because they don't meet criteria for the medication. They're oftentimes losing weight into dangerous areas, and they don't really want that surveillance. So they'll, try and access the medications through means where they're not being monitored. And so the ongoing monitoring is a very, very important piece. This slide just kind of illustrates the treatment trajectory. And this is what I was talking about earlier, is that while um, the gray line here is placebo, the dark blue line is on the medication. Specifically for this graph, it's semaglutide or Ozempic. And then this, or Wegovy, and then this shows kind of like the rapid weight decline while on the medication. But right here, around 68 weeks, when the medication was discontinued, you can kind of see this gradual weight increase that takes place. And so this graph has been pretty similarly repeated with the other classes of medications. And so this is an important piece to kind of explain to patients. So this is kind of like my green, yellow, red that I go over with patients. So when I said surveillance is very, very important, so we need to monitor people closely. And so if they're kind of, having a steady weight loss, they're eating adequately, Every single appointment, I ask patients how much they're eating. If they're eating like less than 1,000 calories per day, that is a red flag. That is not enough fuel. And I will talk with them about increasing their caloric intake. Um, if they're, not being physically active, these medications can cause decrease in muscle mass. So if I have patients that say, oh, I'm just taking the medicine, I'm not doing anything, again, that would be more in the yellow kind of area for me. I'm going to say, hey, what can we do to get you active? These medications can cause you to decrease muscle mass, and that's not what we want. That's not a positive thing. And then if their mood is stable, those are some of the things that it's like, okay, you know, we can continue. We're in the yellow if patients are not losing any weight at all on the medications, because maybe it's not effective for them. There are some non-responders. Maybe there's some underlying eating issues that we haven't kind of unveiled yet, or if they're having excessive weight loss, they're losing like more than 3 pounds a week. I want to find out like what's their caloric intake. I'll talk about this a little bit later. How much protein are they getting in? How much physical activity? And then if they start demonstrating any increase in psychiatric symptoms like depression or anxiety, difficulty sleeping, those would be some things we want to delve into further. And then if any time when they're having abdominal pain, back to the pancreatitis, if they're having abdominal pain, nausea, vomiting, we're going to want to stop or check some labs or check some imaging to figure out what's going on. And then if they're having extreme fatigue, again, that might be because they're not fueling enough. And so we want to ask those questions. We're in the red when we're having extreme weight loss. This is making me think that they're not eating at all. Because one thing patients will say, especially those that are used to having kind of like a high hunger drive, but really all patients say that the medication really takes away their appetite. And so it can be challenging to go from what we're all kind of used to is like picking what we want to eat based on what sounds good or what we're in the mood for, to all of a sudden really having no appetite and nothing sounding good. And so I talk with patients about how you still have to be somewhat prescriptive with your eating. You still need to eat, and the goal is not for the medication to cause you to not eat for any period of time. And so that is one thing I have to continue to reiterate. If patients are gaining weight on the medication, then we want to address that and potentially stop the medication. If they're engaging in any eating disorder symptoms, again, we've talked about restriction, they're not eating enough calories, they're doing binging, purging, anything like that, over exercise, those would be reasons to stop and reassess. But hopefully, if we've done our job and we've screened them at the beginning and we know patients that might be vulnerable, we've gotten a whole team together that can help address that and monitor along with us. And then severe depression or suicidal ideation would be a reason to stop. So, in terms of ethical challenges, it is very challenging to prescribe a medication that someone is taking with the primary goal of losing weight and not contribute to weight stigma. And so that is kind of a fine line that I'm constantly kind of walking along. So I talk with the patients about what their goals are, why those are their goals, especially when we're talking about kids. I find out like, have they been victims of some type of bullying due to their weight? I want to like dive into their motivation and make sure that we're not kind of we're just keeping their global health in perspective and not solely focusing on weight as our only outcome. We want to It's challenging to navigate patients who want medications, but they don't meet the FDA criteria. I have lots of patients that get very upset with me when I won't provide them with the medication when they don't meet the FDA criteria. And so I kind of use that as my guiding light, so that I'm not kind of getting swayed into doing things that are not necessarily medically sound. Um, I educate patients about misleading advertising. I feel like there's so much out there in the popular media. There's this idea that, the medication solves all problems for everyone. And, that can be misleading and it doesn't really talk about the potential risks. And then it's so important for us to identify those kids and adults who might be at risk for disordered eating so that we can intervene sooner and, you know, in a lot of ways, probably not start them on the medication at all, or only start them on the medication if they have the proper support. And then again, that counseling regarding unrealistic expectations and potential for misuse. Even though I have a long conversation with patients at the beginning, I go through informed consent, we talk about expectations. We live in a society where weight loss is constantly congratulated. And so once patients start losing weight, and then I have to remind them, hey, remember at the beginning, we said that we were going to, only lose for this interval period of time. It's time for us to start talking about a weight maintenance plan. They really start pushing back against that, because it's like once they start losing weight, again, that concern of now we're getting more into this restrictive kind of body image thing. They want to keep losing and losing and losing. And so I make sure that I have a lot of these conversations at every visit. And I see patients, if they're on the medications, at least every 3 months. In terms of nutrition considerations, we've already talked about the fact that the medications reduce appetite, so patients might not feel like eating, and they need to increase their protein intake because of the sarcopenia or muscle loss. Oftentimes, they'll also have, with decreased appetite, decreased thirst. So they need to be more cognizant, especially I live in the desert, drinking adequate fluids. And then again, I just said this idea of prescriptive eating where, you may not be hungry, but we need to make sure we're getting in an adequate amount. This just shows kind of a little breakdown of what a meal plan could look like. And I really lean into utilizing technology. So, for instance, like I want patients to meet with a dietitian, but sometimes that might be a few weeks, or they may not be able to see them as quickly or as frequently as I like. So sometimes I'll say, hey, use Chat GPT. Tell it that, I need to be on a higher protein diet. We usually talk about how many grams of protein is appropriate for them, and tell it what's in your refrigerator, and it will pop out some great menus. And so that can be an option too, especially when patients' appetite is low and it's really hard for them to kind of figure out what to eat. We can utilize technology to set alarms and create a meal plan, and make sure that they're eating enough. And then physical activity is important. I talk with patients about, just doing any type of resistance activity that's going to help them to kind of maintain their muscle mass. And then how and when to stop and taper. As I mentioned, that can be a challenge. Usually I talk with patients about when we get closer to like a BMI of, all along, we're going to talk about it. When we get closer to a BMI of like 25, we're going to talk about what that plan would look like. And so, just kind of continuing to keep that as a reminder. So we know with all of the different BMI categories, most of the time on the medications, you're going to lose weight and then begin to plateau. That plateau, when the weight loss kind of evens out, can be different for different people. The average is about 6 to 9 months. It could be longer before you reach that plateau for patients that are potentially on higher doses of tirzepatide or Zepbound. Younger age, back to those of you that are parents, the younger age can be longer to get to that plateau, or female sex. And so I explain to patients, if you stay on the medication long term, your body will get to a certain point where it plateaus, but we may need to switch you to a maintenance dose before your body naturally gets to that plateau, because I'm not going to keep you on a medication to continue losing weight when your weight has gotten to a point where it should be stable for you, based on your past history, height, and so forth. So it's just super important to emphasize that this whole idea of starting these medications can be a roller coaster for people. At the beginning, they're very hopeful. Again, this idea that this medication is going to solve everything. And then when you're taking the medication, they're kind of actively losing weight and getting all of these positive accolades from just random people. And that can be very, have mixed emotions. It can feel good, but then it can also feel like, well, what did you think about me before? And then prior to tapering, or when we're talking about a maintenance plan, most patients get very fearful. They're very afraid of gaining weight. They're afraid of their life going back to what it was when they were at a higher weight, and maybe they were, kind of encountering weight-based stigma. And then after treatment, or if the medication has to be discontinued, there's a lot of angst about that as well. So I just kind of want to illustrate that this can be a roller coaster of emotions, which is all the more reason why it's important to have like a therapist plugged in if we're going to consider this medicine to kind of walk alongside. And this point is just that we want to measure and monitor for suicidal ideation because oftentimes, there is a potential risk. And so we just want to continue to monitor that throughout. And I think the take home point is that there's more to learn. We want to see what the long term safety and efficacy is. We want to see the role of, what if we just incorporate pre screening for everyone, especially for eating disorders and other mental health concerns? And what could this potential impact be for everyone globally for healthcare costs? So there's more to learn. And this is just a preview. I'm getting kind of close to the end. So I just want to talk about some of the medications that are coming down the pipeline. So this cagrosema is one medication that is in the pipeline. This kind of compares it to the mean difference in weight loss. And this is as compared with our currently most effective medication, which is tirzepatide or Zepbound. So we're going to see even higher changes with that medication. This just illustrates that there's a lot in the pharmaceutical research and development pipeline. But what we'll probably be seeing soon are some oral medications. The Carasema that I just showed, I think that was also subcutaneous, but there's also some oral medications in the pipeline. So again, there's lots of medications that are going to be developed in coming years. And so just that there'll be more. This will be a talk that is evolving. And this just kind of talk just shows again some of the differences in weight reduction with some of these medications that are coming down the pipeline, and some of them being oral medications. And in terms of indications, I mentioned earlier some of the current FDA approved indications, but in the future we'll probably be seeing more. There's a lot of research being done on these medications for heart failure, chronic kidney disease. More medications are probably get the indication for the metabolic dysfunction associated steatohepatitis. Probably, we already talked about sleep apnea, that has been added, but there may be more medications getting that indication. There are some there is some research being done for arthritis, substance use disorder, and there's even some animal studies on Alzheimer's disease, Huntington's disease, Parkinson's, and potentially they're not currently indicated for type 1 diabetes, but that may be on the horizon. So, learning objectives. I think we went over a basic understanding of how the medications work, and hopefully, with that understanding, you're able to recognize why these medications would definitely be challenging for someone who is currently struggling with disordered eating or has a history of disordered eating. And I've seen that in lots of patients where maybe they had been in remission for a really long time, but then when they layered on this medication, a lot of those eating disorder symptoms came back. So hopefully in the future, there will be more people out there that are screening for eating disorders and monitoring patients closely. So thank you so much for your time. I think I'm right at time, and hopefully we can open the floor to a few questions.
Thank you. I am so impressed that you got through all those slides in the allotted amount of time. You win a prize because very few people actually can do that. So, um, let's start with the first question, which is how do you decide on weight goals for patients?
That's an excellent question. So I usually will chat with patients about what their weight goal is, just so I have an idea of like what their mind frame is. And then I will look at their overall weight history and kind of like what's been the common weight that they've maintained. And because depending on their history, their weights may have been all over the place, but ideally trying to find like what's that rate range they've been able to maintain without engaging in any kind of extreme restriction or over exercise. And then I'll also look at like their current, BMI. And so I'll use all that information to kind of come up with an overall goal. But I explain to patients that, we're going to collaborate on a goal, but it may not be whatever your emotional goal is. Because a lot of times when you ask someone, what's your goal weight? Their goal weight is something either when they were in high school, or it's something when they had an extreme weight loss due to severe restriction and they want to go back to that. And so we kind of talk about the fact that that might not be a place that your body is going to be able to maintain in a healthy way.
Thank you. Um, is there evidence that these medications are indicated for people with eating disorders? I mean, you talked about, kind of like the other side of that, but are there indications that sometimes, there is evidence that that is the right thing to do to prescribe them?
No, so there is not current. So when I think about evidence, I think that the evidence has risen to the level that you can take that evidence to the FDA and get an FDA approval for that indication. So is there some anecdotal conversations with small volumes of, patients that there has been some improvement in some symptoms of eating disorders? Absolutely. But is there enough kind of overwhelming evidence that that the companies have been able to go to the FDA and get approval for that indication? No, but there is some anecdotal evidence that, it may help, for instance, in decreasing um, like binge behaviors. I've seen that one specifically. And I've heard that there might be some other emerging evidence in other eating disorders, but there is not currently any FDA indication for these medications for eating disorders.
Okay, thank you. Um, I want to switch gears a little bit. We are a parent community. Um, and some parents in our community are on these medications. And I would kind of like to talk about, from your perspective, what can we do as parents to protect our kids? Um, you know, because these medicines really are all encompassing when you're on them, and they kind of become your world. And so I'm just curious as to how you would navigate that as a parent.
Well, I think if in terms of a parent being on the medication, first and foremost, safety comes to mind. So I have heard of some instances where children have been able to get access to their parents' medication and then have had some adverse side effects. So making sure that those medications are kind of put away and in a safe place so that someone that is not prescribed the medicine does not have access to it. And I think, you know, in general, when we're dealing with kids, we want to emphasize kind of overall health. I tell all parents to not have over focus and emphasis on, talking negatively about their body or the bodies of others, making sure that you're modeling kind of good eating habits in front of your children, that we're having sit down meals together, that if you are on this medication, recognize, hey, mommy or daddy has an indication to be on this medication, but we're still eating and moving our bodies and doing all of the things that are important to maintain our health. So I think in any instance, when we're talking about children and vulnerability to eating disorders, one of the things that makes them significantly vulnerable is that negative body talk, overemphasis on weight, and just, too much emphasis on like good and bad foods versus like, we're all as a family eating a variety of foods and maintaining our health. So I think those are some ways that as parents, if you're taking the medications, you can still model these behaviors for your children that can help protect them from eating disorder or vulnerability.
Thank you. Before we go on to the next question, I meant to ask you to unshare your slides just so we could see you better for the Q&A. Sorry. There you are. Now you're big. Thank you. Okay, so I had the same question, which is what age is too young for these medications, which kind of ties in to somebody who also asked about her 14-year-old who had anorexia, and now her BMI is 25. So, they're kind of looking at you know, should she lose weight and how should she lose weight at that BMI at 14? So let's talk about the age of, when you would prescribe these.
That's a great question because I feel like 14-ish might be the cutoff. I will have to double check that. But There, so currently, I sit on a work group with the American Academy of Pediatrics because they did come out with a statement regarding, management of weight in children and adolescents, and these medications were part of that. One of the things that was concerning from an eating disorder perspective is that there was not enough emphasis on screening prior to initiation of these types of medications. There was a lot of great evidence in there about, that baseline lifestyle stuff that we would want to support, and we would like to see more screening and screening be available at younger ages. But I think in general, I would say adolescents. I want to say 14, and only one of the medications currently has an indication for adolescents, and that's the Wegovy or semaglutide. Um, and I would say a child with a history of anorexia currently at a BMI of 25, they would not meet criteria for one of these medications. So it wouldn't be even really a conversation. I think it would be back to all those things we talked about in terms of like, positive body image, physical activity, and, kind of balanced dietary intake.
Okay. Thank you. Um, okay. Anybody else have any questions? Because we're actually out of questions, which I'm very surprised because usually we run out of time. Um, Anyone else have questions? Just throw them in the chat. Leslie, do you have anything else you want to put out there since you do have a little bit more time?
Oh, I love it when I have more time. So I'm um, think about things that I want to put out. No, I feel like I, gave a summary of the medications. I think it's just really important when we think about these medications and treatment of children or adolescents. I think it's really important to make sure that we are balancing really what the child's desire is. Because what I see a lot of times with kids is that the parents are bringing them in, concerned about their weight trajectory and wanting to start them on a medication, and I think it's important that, we're doing all of that fundamental kind of lifestyle stuff before we kind of go to a medication, and that it's something that the child is personally interested in. It's not just the parents that are coming because of their own concerns. And on the flip side, I think if there's a kid that's interested, but the family themselves hasn't really been bought into like all of those lifestyle changes and everything, and the kids aren't aware of all those nuances that we talked about in terms of like insurance coverage and everything. So it needs to be a team sport.
I mean, look, I know that we at Feast were very concerned when the AAP guidelines came out, because they didn't seem to see people with eating disorders or, take that into account. So I'm very glad that you're in this working group because we need voices of doctors who are experts at eating disorders so that you can make sure that our kids are protected, and that these concerns are, addressed. So I'm really appreciative of that. We have a question about if someone has a history of laxative use, or I guess abuse, is that contraindicated for GLP-1s?
So I wouldn't say that it's a contraindication, but I would, of course, we would not want them to be currently taking any laxatives, and we would definitely want to monitor them closely. And that would be someone that we would want to be very slow and kind of careful in terms of being on the medications. Because again, if it slows down the GI tract, back to it increasing your vulnerability. So if all of a sudden you've gone a day without a bowel movement, and then your knee jerk response is, I need to have a laxatives to have a bowel movement, and then that's going to start you in that cycle of kind of that laxative abuse. So it's definitely a reason. It would be in my yellow of a reason for caution.
Next question. Why should patients not stay on these medications for the rest of their lives? Is it more of a concern of cost? Um, or is there potential harm to health when used for long-term or lifetime use?
Excellent question. So I think that's why it's in that we don't yet know category, right? I can't say that there's long-term negative health impact. It's just that we don't have enough long-term data. Most of the data that we have is, just in the use over a couple of years. We don't have enough impact in terms of long-term data to see what it's like if you're on these medications for decades. And so that's where it's a question mark. And so, for instance, if we're thinking about these in the context of children, we know that when you stop the medication, there's that potential for rebound weight gain to maintain the weight loss. The evidence seems to support that patients need to be on that um, long term. And so I can't tell a 17-year-old what the impact is of being on this medication for 10, 20 years. You know what I'm saying? And so that's why it's an important conversation to have. Like, hey, if you're 17 and interested in weight loss and we haven't done all of these other lifestyle stuff, let's do that first. Let's see what happens as the evidence evolves, and let's determine whether or not this is going to be safe for you. So I think it's more of a more to come.
Thank you. From one last question, from an eating disorder lens, with individuals with anorexia, do they have a potential lack of GIP function in their gut?
That's an excellent question, and I think that that may be the case. I don't know of the research of that off the top of my head to say, like, if we take a group of anorexics and we monitor their overall GI function or GIP function. So that's where, there's so much more to come in terms of how this is evolving, but that could potentially be.
Thank you. This was really fascinating. This is the second time I've heard you speak on this topic. After the first time, I was just, I really wanted to bring you into Feast because I really love the way that you approach this. It's not an easy topic. There is a lot of controversy, and I think that you're very measured and level-headed, and you know, I guess you really think things through, which I think is so important. So, thank you so much for being here today, and thank you everyone for joining us. I just want to let you know that if you were here today and you appreciated this program, and you have the means to donate to Feast, all of these programs are run through the generosity of people who donate in our community. So if you want to take a moment, go to our website and donate. We would really appreciate it. And I would also like to invite you to next month's webinar, which is in collaboration with the Emily program. The topic is, when is a higher level of care needed? That is a topic that, we hear in our community all the time. Parents just don't know if the level of care their child is getting is adequate, if it's the right level of care. So Dr. Brad Smith is going to be talking about that. He's a real expert, and I'm sure it's going to be a great webinar. So again, thank you so much, everyone, for joining us today. Thank you so much, Dr. Williams, and have a great day or evening, depending on where you live. Bye, everyone.